So I'm going to talk about the different contrast agents and how they may contribute to contrast-induced nephropathy. These are my disclosures. Does contrast agent selection matter? So in order to answer this, I'll talk about the clinical practice guidelines in regards to contrast use in terms of their change over the years and the data supporting that. The effect of contrast agents on incidence of renal toxicity or contrast-induced nephropathy, and then I'll finish talking about some outcomes data that we've recently worked on. So these are the contrast agents that we're talking about. You can see in the 1950s, we used predominantly high osmolar contrast, and then in the 80s and 90s developed low osmolar contrast, and then subsequently in the 90s, Iso-Osmolar contrast. The panel on the right basically just shows the osmolality in terms of each contrast agent in terms of comparison to blood. So why do we care about this? This was discussed previously, but you can see that based on this national inpatient sample from 2001 to 2011, over 3 million patients who underwent PCI, you can see that the rate of contrast-induced nephropathy is increasing in the panel on the right, although to a lesser extent mirrors the contrast-induced nephropathy or acute kidney injury from that requiring dialysis. Here are the evolution of the guidelines back in 2007. Actually, it was a Class 1A recommendation for patients undergoing angiography to receive iso-osmolar contrast. And in 2009, this was updated, and basically the wording was modified that it was either iso-osmolar or low osmolar contrast. And then finally in 2011, this was completely deleted. And I'll talk about some of the evidence behind this. Actually, if you look at the European guidelines, they're more consistent with what the 2009 guidelines were in iso-osmolar, in terms of using iso-osmolar contrast with low osmolar contrast, and actually consider one or the other. And these were the cited studies that they used, and they're really the same data was used to determine these recommendations, and thus, in my opinion, would be open to interpretation. So in the 90s, this meta-analysis looking at the nephrotoxicity of high osmolar contrast basically showed a benefit from using low osmolar contrast with reduced contrast-induced nephropathy. Subsequently, the high osmolar contrast were never used. This is a seminal study, a nephric study. 130 patients were randomized to, they had diabetes and chronic kidney disease with a creatinine ranging from 1.5 to 3.5. Were randomized to either iso-osmolar or low osmolar contrast, and there was a statistically significant benefit to receiving iso-osmolar contrast with reduced contrast-induced nephropathy. Subsequently, several studies have really not shown this. RECOVER-1 showed a benefit, but then CARE and VALOR did not, and this is really what led to the changes in the guidelines. I'd like to point out a few differences amongst these studies that may explain why there were negative studies. You can see that the contrast agents, the low osmolar contrast agents, was different in each study. The patient selection in terms of diabetes, the percent of diabetes, nephric study had 100% diabetes and the rest were much less. And there was not standardization in terms of collection of creatinine. You can see, and even looking at their baseline creatinine, some of it was done post-hydration, and you see a mixture of results here. Subsequently, then this led to many meta-analyses, of which I put this up here just to point that out, that there are several meta-analyses that have been done. And you can see that there's a mixture of benefit and not benefit to using iso-osmolar over low osmolar contrast. But there is a trend, and also I'd like to point out here that highlight a few things with these studies, that there was, even in the studies where they were equal, there was still benefit over certain contrast agents, and also that there is benefit to using iso-osmolar contrast in intraarterial, but there's no difference really in the contrast-induced nephropathy and if it's injected intravenously. So the incident, excuse me, I'm going to move and talk about some outcomes data. You can see here that, excuse me, that was just presented in our last talk that why do we care about this after PCI? Excuse me. The incidence of death, bleeding, and MI increases with acute kidney injury after PCI, and it's higher in patients requiring dialysis. So we looked at this in a large data set of the Premier database, which is a claims database, looking at iso-osmolar contrast media and adverse renal and cardiac events and after percutaneous cardiac intervention. The aim of the study was to assess a relationship between iso-osmolar versus low osmolar and major adverse renal and cardiovascular events. Primary endpoint was major adverse renal and cardiovascular events, or MARS. This was previously described in some of the nephrology literature of Chawla, and essentially that is just major adverse kidney events added to major adverse cardiovascular events. Coronary and peripheral angioplasty visits from the Premier database were stratified into two cohorts, iso-osmolar and low osmolar contrast media, and then multivariable regression analysis was performed. This is the Premier database. It's over 500 participating hospitals, inpatient, outpatient encounters. There was data from hospital discharges that include demographics, diagnostic procedures, billing services, medications, and laboratory services. And there was also some hospital characteristics as well. So here's the attrition diagram. Started off at almost 250 million visits for 73 million patients. Once then the visits with patients who got contrast and a cardiovascular procedure down to 571 million, and then where that primary procedure was angioplasty and contrast media, 333 million patients. And we only analyzed hospitals where there was both iso-osmolar and low osmolar usage, which was about 75%. Here's some patient characteristics. You'd note that patients who received iso-osmolar contrast media were older. They had underwent peripheral procedures primarily, or higher number underwent peripheral procedures. They had diabetes with or without complications, renal disease, and they appeared to be sicker based on a Charlson comorbidity score. So relative risk reduction. The iso-osmolar contrast media was associated with a 9.32% relative risk reduction for Marseille events compared to LOCM. This translates into an absolute risk reduction of 0.69, which is the number needed to treat of 145. So in summary, there is a positive data of head-to-head randomized clinical trials comparing contrast agents. The results of both randomized clinical trials and pooled meta-analyses are conflicting, but largely trend towards the benefit of iso-osmolar in high-risk patients. Studies are limited by lack of standardization, inclusion criteria, and outcomes with long-term follow-up. And interestingly, despite a change in practice guidelines, Premier database would suggest that iso-osmolar is actually still used in high-risk patients and intra-arterial contrast injections. This Premier registry data suggests that prior studies that demonstrated reduced contrast-induced acute kidney injury could translate into clinically meaningful outcomes. But as always, larger studies are needed, either randomized or larger registry data. Thank you.